Hello everybody. Our lecture today is about space analysis. So what is space analysis? It is a method to provide a numerical value for the space required within each dental arch to treat a malocclusion. So we need to get this number to help us in the treatment of the malocclusion. The Royal London Space Analysis is the most common one used in the UK, which basically they produce this kind of analysis that depends on the most recent evidence that they got at that time. And mainly in this lecture, we're going to discuss how the Royal London Space Analysis is done. But before that, we need to have some definitions to make that these are clear. First one is what we call it the arch perimetry, which basically the distance between the mesial contact of the one sex on one side to the other sex on the other side. That's we call it the arch perimeter. The second definition is the intermolar width and the intercanine width. So the intermolar width basically is the distance between the mesobuccal cusp tip of the upper sex on the right side to the mesobuccal cusp tip on the molar on the other side. While the intercanine width is the distance from the cusp tip of the canine from one side to the cusp tip of the canine on the other side. The last terminology is what we call it the arch depth, which basically it's a line perpendicular to the line joining the mesial contact point of both molars on both sides. So that line in green here, we call it the arch depth. So whenever we do a space analysis, we have to think about the space available that we have, and then the space required that we need to treat this malocclusion, and then we compare them. So either we have an excess of space, or the space is just enough, or we have a deficiency of space, and then we have to think how we're going to provide the space. So when the Royal London analysis came up, they think that we have, when we do a space analysis, there is 6 points that we need to consider. The first one is crowding or spacing. Second one, leveling the curve of Spee, arch expansion and contraction, incisor AB position, angulation changes, and inclination and torque. And we can give a positive or negative sign depending on whether this one is going to give us space or take a space. For example, if we have crowding of 3 mm, that will be a minus sign. But if we have a 3 mm of spacing, then this is a positive sign. And this is the form that is proposed by the Royal London Space Analysis. For today's lecture, we're going to discuss this part, which basically the space requirement. And for the next lecture, when we do the treatment planning, we're going to discuss how to provide space to treat this malocclusion. So the first one is to measure crowding and spacing. So first of all, in order to measure the amount of crowding that we have, we need to measure the space available. So how can we measure the space available? The first method is to use what we call it the brass wire. So you measure the arch perimetry, which basically from the mesial side of the sex on one side to the mesial side on the sex on the other side. And use a brass arch wire to do that. The second method is to divide the arch into segments, and then from the mesial side of the sex to the distal of the canine, then from distal to the mesial of the canine, then from the mesial of the canine to the midline of one side, and then you repeat that on the other side. So basically you're dividing the arch into 4 segments. However, dividing the arch into segment is more reliable compared to using an arch wire. So if you compare both of them, we prefer this method because it's more reliable. However, if you think about the brass wire, there's a problem with that how are you going to decide the arch form? So if you look here, for example, in the lateral incisors, you can see that they are retroclined. So are you going to consider this as the arch form? Or are you going to consider the central incisors? There is advantages and disadvantages for each of them. However, it's kind of recognized that you use the arch form that represent most of the teeth. So this is kind of weakness of this method. Coming back to the dividing the arch into segments, but we know that the arch is not a segment, it's an arch. Well, converting it into segments will create problems. Johal and Batagil in 1997, they did a study, compared these two methods, and they found that the weakness of the brass wire, that it's kind of overestimate the space available. While the segmented wire, it's gonna underestimate the space available and give you more crowding, which means that you need more extraction. So then, once you measure the amount of space available, you need to measure the amount of the space required. So you measure the mesodistal width of each individual tooth. So then you subtract the space available minus space required, and if you get a minus, that's crowding. If you get space positive, that's crowding. But as we mentioned before, there's a problem with both methods of detecting the space available and also the space required. We have to measure each tooth individually, which means that we need to repeat this measures 10 times in each arch. Now, as much as you repeat the measures, the chances of having more error is more. We call this an accumulative error. Even a small error, when you do a lot of steps, that will be accumulated to a big error. For that reason, the Royal London said, okay, no, we don't use this method to measure crowding. What we do is, we look at the arch, we pick the arch that represent most of the teeth. And we're going to come back to this later because this is very important when we decide the overjet. So for example, for this one here, you have two central incisors. One of them is ahead of the other. So the one on the right side is ahead of the one on the left side. So if I consider this one as my arch form, then this tooth is not crowded, well, this one is. However, this tooth having an increased overjet. So that now we need to count it in the crowding and we need to count it in the increased overjet. So this is something that we need to consider when we do the measurement of crowding. Where is the arch form? And then what this suggested is to use a clear ruler on top of the study models, in which, for example, if you have a crowding for this lateral incisors, first you measure the space available for this the lateral incisors, and then you measure the mesodistal width of this tooth, and you subtract them. So as if you're doing the space available and required for each tooth. And that's how Royal London recommend this technique, to avoid the mistakes that we mentioned about measuring the space available and the space required. So basically by this, you're reducing the number of steps that you have to do, and by this you reduce the accumulative error that might happen. When you have two teeth that are crowded like this, what they recommend by Royal London Space Analysis, that you measure the distance from, for example, in this case, from the mesial side of the 4 to the distal side of the central incisor, and then you measure the mesodistal width of the lateral and the canine, and then you measure the space available and required. You can do this up to 2 teeth. However, in a situation like this, when we have 3 teeth, you can't do that. So you can't measure from the mesial of the 6 to the distal of the 2, and then you say that these are 3 teeth, because there now it will become inaccurate, because it's gonna eliminate the curvature, the nature of the curvature of the teeth. However, don't miss this technique, what we call it the overlapping technique or the eyeballing. So basically what you're doing with the overlapping, you look at the overlap between the contact point. So for example here, if you look at this lateral incisors, if I'm going to do that according to the Royal London Space Analysis, I will be measuring this one, this space, and then the mesodistal width of the tooth, and subtract them from each other. However, the eyeballing, or the overlapping, I measure how much overlap between each contact point, which represent the amount of the crowding. So for example here, the overlap between the mesial side of this lateral incisors and the distal side from this central incisor, which was almost here a 1 millimeter, represent the space required to align this contact point. And it's the same here, so that would be 1 millimeter, so that's in total 1.5 millimeter of crowding for this tooth. And then you do the same for each overlap in the contact point, and you then add them together, and the sum of that will be the amount of the crowding. It's a good method to do it, but this is not the method that is recommended by the Royal London Space Analysis. This method, we use it in the clinic when we do the examination on the patients. So now we're done with the crowding and spacing. The second step is leveling of the curve of Spee, or the occlusal curve. So as you can see here, that we have the curvature, the curve of Spee. So that's one, it's kind of curved line. If I'm gonna make this line straight, by default this teeth has to move forward a little bit, which means that I need space. So that's why leveling the curve of Spee, it requires space. How we measure it? we measure it from the distal side of the first molar, distal cusp, to the incisal edge, and then we measure the deepest point, which usually represent the molars. However, just to keep in mind that we don't consider the tooth if we measured it for crowding. So for example, if this 5 here was rotated and we measured that 5 in crowding stage, we don't take this measurement, but we take this one. So for each 1 millimeter of, for each 3 millimeter depth of the curve of Spee, we need 1 millimeter of space, while for 4 millimeter depth, we need 1.5 millimeter, while 5 millimeter of depth needs 2 millimeter of space. And then, even though if it's increasing more, we don't need more space. And the reason for that, because as you can see here in this paragraph or this diagram, that when you have an increased depth of the curve of Spee, that's resulted in a slippage of the contact point between neighboring teeth. So here, the contact points are not at the same level. So to get this, for example, 5 up, to have the contact point at the same level, we need more space because the teeth look triangle. But then once they are there, you don't need more space because now there's no more, because of the anatomy of the tooth, it's get narrower. So that's why if it's more than 5 millimeter, we don't need more space for the leveling of the curve of Spee. So just to summarize it, if the premolar is counted for crowding, we don't count it more, we take the deepest one. Think about the leveling of curve Spee as just making the contact point at the same level. Then we move to the arch expansion and contraction. So what the Royal London Space Analysts recommend that for each 0.5 millimeter of, for each 1 millimeter of increase in the intermolar width, that will result in 0.5 millimeter increase in arch perimeter. However, don't forget something, that when we do the expansion, the arch depth will be reduced by about, so for each 1 millimeter of expansion, we get 0.5 millimeter of space, increase in the arch perimetry, and reduction in the arch depth by around 0.28 millimeter, because the incisors are dropping back when we do the expansion. And then the incisors AB position, which basically the overjet. So if you have the upper incisors here and you retract the over incisors to reduce the overjet, for each 1 millimeter you need 2 millimeter of space, 1 millimeter on each side. And it's the other way around. If you procline the incisors, each time you procline the upper incisors by 1 millimeter, you get 2 millimeter on each side. But when we measure the incisors, we need to consider carefully the arch depth, the arch form that we are using. So for example here, as you can see that we decided this is our arch. So when we measure the overjet, this is the tooth that I'm measuring the overjet, because you have to measure the biggest overjet that we have. And in the same time, we will have measure this one as a crowding, because if it's crowded and rotated, I mean. So we need to take into consideration whenever we measure the overjet, we need to consider first the arch we are using, and then we consider the tooth if it's away, and we need to reduce the overjet. So if you're looking to this case, for example, the overjet is 5 millimeter. This is the upper arch and this is the lower arch. Now what we need to do is to reduce this overjet into 2 millimeter. So that means that we need the 3 millimeter to retract the upper incisors posteriorly. That means we need 6 millimeter on each side. However, whenever you plan your overjet, you need first to plan the lower arch, then you plan the upper arch. Because as you can see here in this case, the amount of the crowding in the lower arch is almost 4 millimeter. And if we decided to treat this patient non-extraction by proclination of the lower incisors, 4 millimeter, it needs 2 millimeter of proclination, because each 1 millimeter give you 2. So we will procline the lower incisors by 2 millimeter. That will reduce the overjet into 3 millimeter. And now we don't need 6 millimeter to reduce the overjet, which is the 3 millimeter. What we need is only 1 millimeter retraction of the incisors, which required only 2 millimeter of space in the upper arch. So whenever we plan the overjet, we need first to plan the lower arch, and then we plan the upper arch around the lower arch to measure the amount of retraction that we need. Then we talk about the angulation changes. So if the upper anterior teeth are upright, they will take less or consume less, less space than if they are mesially angulated. And as we all know that all the teeth, according to the Andrews 6 keys of normal occlusion, that the teeth should be mesially angulated. So if the tooth is completely upright, and then we need to give it the mesial tip, it needs about 0.5 millimeter of space to correct each tooth that is upright and give it the correct tip. And that's only for the maxillary incisors. Only for the maxillary incisors. Now, what you need to think about is that if the tooth was over tipped before we start the treatment, let's assume that we need 5 degree, positive 5 because it's mesial, tipping of the central incisors. If mesial tip. If they are before the treatment positive 10, and then you upright it into positive 5, that gives you space. But if it's minus 5, meaning that it's distally tipped, uprighting into positive 5 does not take you or give you a space, because already when it's distally tipped, it's taking and consuming space. So in order to calculate the space, the tooth has to be upright, and then we tip it to that way we consume it, we consider it as a space requirement. The last one is the inclination or the torque. So this one here we need to consider carefully. So this is the retroclined central incisors. And in order to correct the inclination of this central incisor, there's two ways of doing it. The first one, by simply tipping the crown forward to procline the incisors. So the crown will move in one direction and the root will move in the opposite direction. This will result in movement of the crown forward, which basically a proclination. That will give you a space, but it will increase the overjet. So if you don't, and that will not consume space. On the other hand, no, it gave you space. While the other diagram here, if we doesn't want the overjet to increase. So what we need to do here, to convert this one into here, we fix the crown and all the movement will be done by the root. We call this torque. So if we apply a palatal root torque to this central incisors, that needs space in order for the overjet not to increase. So we either accept an increase in the overjet by proclining the incisors, that will give us space, or we keep the crown where it is and we provide only movement of the root, and in this case we consume space. We need space. The teeth that needs more space are a parallel sizes. So the anatomy of the teeth as well decide how much space we need. So the triangular teeth are the least one to require space, while the parallel sided are the most teeth to need space when we torque them, and the parallel shaped one, they comes in the middle. And that's something why the lower incisors, they are not counted in when we consider torque and tip. Because of the anatomy of them, they look mostly triangle, and they are small in size, so they're not really counted when we consider the space. So applies only to the torque thing applies only to the maxillary incisors. Allow 1 millimeter of space for every 5 degrees changing, affecting all 4 incisors, and 0.5 millimeter of space if only 2 teeth are affected. So as the space implications are relatively small, the angulation and inclination scores are combined on the space planning form, because usually these are kind of minimal space requirement. As you can see here, angulation and inclination, they are done in the same paragraph. So by that, now we've finished the Royal London space analysis. So is the Royal London space analysis good? What about the evidence? Maryam Al-Abdallah did a study in which she tested the reliability, which meaning the reproducibility of the Royal London space analysis, and it found it's reliable. Yeah, each time you do the measurements, it is the same. However, the Royal London space analysis does not affect or influence your treatment decision, and it does. But however, it might influence your visual perception of crowding, and it kind of have an impact on the judgmental variation of the crowding. What is the most common disadvantage of the Royal London space analysis? That at first it does not account for vertical and transverse problem. All we're talking about is anteroposterior problem. And as we can see we saw by study by Mariam Abdullah, it does not really affect the treatment decision, because the orthodontist sometimes, if you think about something, just go for that one. And unfortunately, it tends to overestimate crowding. And whenever it's overestimating the crowding, that means it kind of push you toward an extraction. So whenever you do space analysis using Royal London space analysis, just keep in mind that this kind of space analysis push you toward an overcrowding and toward the extraction. So before we finish, we just need to talk about two things more. The first one is the estimation of the size of unerupted teeth. So the Royal London space analysis does not mention anything about the primary teeth. So what's happening if we have a patient like this and we need to assess the amount of crowding? So we have permanent teeth and we have a permanent primary teeth. All what we need to do is to estimate the mesodistal width of the unerupted teeth. And we can now do Royal London space analysis or the assessment of crowding if we want to. So how can we estimate the size of the mesodistal width or the size of the unerupted teeth? The first one is to use a radiograph. In order to use a radiograph, you need to have periapical radiograph for each tooth, and it should be non-distorted radiograph. However, if you take, which means, by the way, a lot of exposure and radiation, because if you repeat periapical, that is not necessary just for the space analysis or to measure the amount of crowding. It's kind of not justified to expose the patient for this number of X-rays. And the problem with the X-ray that even if you get that one, still the canine will be distorted in the X-ray. As you can see here, even in the OPG, that the canine, because its location on the corner, is always distorted. So it's really hard to detect even in the periapical. But the advantage of this technique that it has no limitation when it comes to the ethnicity. You can use it on white, black, Hispanic, Asian, Caucasian, Indian, whatever ethnicity it is, because it's the X-ray of the patient. So how can we use it? So for example, if I want to measure the mesodistal width of this unerupted 5. So simply what I do is I go to the study model and the cast and measure the mesodistal width of the 6 on the cast. I say, okay, for example, it's 10 millimeter. And then I measure it again on the radiograph. So I'll be saying, okay, on the radiograph, this 6 is 10 millimeter, while on the cast, it's 8 millimeter. So then I measure the mesodistal width of the 5 on the radiograph, and let's assume it's 9 millimeter. So it'll be like, so the 5 is 9 millimeter on the radiograph, how much that will be on real life, and then you do the calculation and you get the mesodistal width of the unerupted 5. So the main disadvantage of this technique is that too many X-ray, you need the X-ray not to be distorted, and that will be really difficult when it comes to the canine. But the main disadvantage for this technique is the amount of radiation that we expose the patient to. For that reason, an estimation of mesodistal width of the unerupted teeth came from what we call it a proportionality table, and that was one introduced by Moyes. So what he did propose that if we measure the mesodistal width of the lower incisors, from that we can estimate the mesodistal width of the lower 3, 4, and 5, and the mesodistal width of the upper 3, 4, and 5 from these tables. Now, this is a good technique if it is used with the ethnicity, which basically the white Caucasian that on this study was done on. But we can't really apply it to a different population. And you can think about why we use the lower incisors to guess the mesodistal width of the upper 3 and 4 and 5. Why not to use the upper, central, and lateral in the upper? And the reason for that, because the lateral incisor is variable in the mesodistal width. So it's a lot of time that the lateral incisor is either small or big shape. So it's not reliable and valid for us to use it to get the mesodistal width of the unerupted teeth. For that reason, we use the lower teeth to guess the mesodistal width of the lower and upper incisors. Moyer's table is a very good table. It's nice and it's very good method, and but the only issue, and it doesn't need the radiation, it does not need an X-ray, but it needs to have the table with you all the time, which kind of problem. For that reason, Tanaka and Johnston, they said, okay, it's the same method as Moyer's table, but instead of that, you just need to memorize an equation. And that equation, it's again, they use the mesodistal width with the lower incisors. You just half in that one, and you add to this one 10.5 if you are want to estimate the mesodistal width of the lower 3, 4, 5, or you add 11 if you're going to do that in the upper arch. Now, the good thing about the Tanaka and Johnston, if you memorize the equation, you don't need radiograph and you don't need the table. You can do it immediately. However, it's only good for children from the European population where the group of the study is done. So we can't really apply it to the Middle Eastern population. This method has a good accuracy despite a small bias toward overestimating the size of the unerupted teeth. And as we mentioned, it requires neither a radiograph nor a table. The last method is to use combination of radiograph and prediction table. So because of the problem that we face with the mesodistal, the distortion of the canine, this method combined the using of prediction table and an X-ray to measure the mesodistal width of 4 and 5, and then you use these numbers on a table to get the mesodistal width of the canine. It always gives you the mesodistal width of the lower canine. The problem with this method, it's very accurate, but the problem with this method that you need a radiograph and you need a table to use it. Last thing to talk about in this lecture is the tooth size discrepancy. Now, Andrews proposed 6 keys to normal occlusion, and then McLaughlin, Bennett, and Tevez, they introduced the 7th one, which is the tooth size discrepancy. So in order to get a good fit between the upper arch and the lower arch, the size of the teeth in the upper should fit and match the size of the teeth in the lower. So to make it clear, if you remember when you used to do setting of teeth in a complete denture, so you get the size of the teeth. So if you use a smaller teeth in the upper, for example, with a bigger teeth in the lower, they will never fit. Simply because this is the sizes of the teeth did not match. Now, most of the time, the size in the upper teeth matches the size in the lower teeth. It's only 5% of the population where is the sizes of the teeth doesn't match. However, most common cause of this is the size of mesodistal with size of the lateral incisor. That is the main issue that we face, or sometimes then followed by the premolar. Now, to diagnose this tooth arch size discrepancy, we have 2 methods. The first one, which is the quick method, that you use the canine, the lateral incisor in the upper, and you compare it to the lateral incisor in the lower. Usually, the lateral incisor in the upper should be bigger than the lateral incisor in the lower. But if they are equal in size, or the lateral incisor in the upper is smaller, that means that we have a tooth size discrepancy. We do the same with the premolar in the upper, the 5, the second premolar in the upper, and the second premolar in the lower. If they are in the same size, then we don't have any tooth size discrepancy. The second method to do it is to use what we call it Bolton discrepancy. So basically it have an overall ratio and an interior ratio. So you sum the mandibular teeth, the whole of them, divided by the sum of the maxillary teeth multiplied by 100. That will give us a proportion of 91.3%. Or you can do the same but for the anterior teeth. So for example, let's take the anterior teeth ratio. It's 77.2. So if the number, for example, is 85, that means one of 2 things. Either the mandibular teeth are too big or the maxillary teeth are too small. In these cases, to get a perfect fit of the occlusion, you either have to do stripping of the lower incisors or to do build-up of the upper incisors to correct this kind of malocclusion and to get a better fit. However, you just need to keep in mind that Bolton analysis is dependent on the study done by Bolton, and it's accurate, and the sample was only white female patients. So that means it's only not only for a special ethnicity, and it's also on one gender, on a female. And that's something you need to keep in mind when you do a Bolton analysis. Othman and Haradine, they studied Bolton analysis, and they said that repeat measurement for the tooth size discrepancy I recommended. And why is that? Because it's highly not reproducible. And the cause for that, because you have to measure the mesodistal width of the whole 12 teeth in the upper and the whole 12 teeth in the lower. And we said before in the space analysis, this will result in an accumulative error. So you do a measurement 12 times in the upper, 12 times in the lower. That will mean 24 times measurements. So then each time if you have a fraction of a millimeter of an error, that will be accumulated to be a big error. For that reason, Bolton analysis is not reliable. So you need to repeat the measurement more than one time. And again, for that one, computerized method is better than the manual method. That was all. Thank you very much.